Hi, folks. Sorry about that. It looks like the chat is disabled. I have called on Enrico to come back and save us. In the meantime, it looks like the Q&A box is working. So we'll get started. I think we can go ahead and get started. And then please, in the meantime, put your questions into the Q&A box, and hopefully we'll get the chat working again shortly. My name is Stacy Tannenbaum. I am one of the two co-chairs of the Statistics and Pharmacometrics Special Interest Group. We are a joint special interest group with ISoP and ASA. My co-chair is Mike Smith, who unfortunately had a conflict today and couldn't make it. We're really excited that this is kicking off our SxP webinar series. Our goals are to have education in SxP relevant topics and really engage a wider group of members than we could at a face-to-face meeting. Of course, we haven't had a face-to-face meeting in some time. Fingers crossed that we can do that again very soon. Our steering committee members will curate the topics and host the events. So if you have a particular topic that you're really interested in learning about or speaking about, please contact us. You can contact me or you can go to our website, and I'll put the website the website name in our chat. Hopefully you can see the chat, and then you can click on the website and then join us as well. Our next webinar that's coming, we don't have a date for that yet, but will be MIDD Opportunities for Collaboration between Pharmacometrics and Statistics. And that is a reprise of a DIA session that Hao Zhu and Lei Ni, who is a pharmacometrician and a statistician, both from the FDA, have given. And we're really excited about that. Please watch this space for more information on that. But let's jump into our topic of today. I'm very, very pleased to introduce our two speakers. They are the co-chairs of the Mbma Sub-SIG within SxP. Our first speaker is Matt Zierhut, and I apologize if I'm murdering both of your names. I hope I do this right. But Matt is a scientific director of statistics and decision science at Janssen Pharmaceuticals. He focuses on integrating modeling and simulation concepts into drug development strategy and decision-making with an emphasis on MBMA. He holds a PhD in bioengineering from UCSF and UC Berkeley and an MBA from UC Berkeley Haas. He has more than 12 years experience in the pharmaceutical and management consulting industries. In his spare time, Matt enjoys spending time with his kids and family, going on camping adventures, playing volleyball, and relaxing whenever possible. I am very jealous that he lives in San Diego, California, with his wife and 4 children. Right now, it is snowing like crazy here in Chicago, and I wish I was in San Diego. Marion Bouillon-Pichault, hope I said that right, is currently a director of MBMA in the Quantitative Clinical Pharmacology group at BMS. She leads the effort to implement MBMAs to support drug development. She received her PharmD and her PhD in pharmacometrics from Paris Descartes University in Paris, France. And over the last 10 years, she's been holding different pharmacometric positions in pharma and consulting companies in Europe and the US. She lives in Princeton, New Jersey. She likes to do Pilates, cook with her 2 children, and prepare their next family travel. I really hope that you can do that soon, Marion. As a reminder, a little bit of housekeeping. We do have a chat box, which apparently is not working. I apologize for that, but you can put your questions into the Q&A box. That does seem to be working. And hello, Jeff, as well. We will be chatting responses in the Q&A box, and hopefully you can see the responses to that. And at the end, we will come back for a live Q&A. Please put your questions in there. Marion and Matt will be answering questions throughout the presentation because this is actually going to be a recorded presentation, as well as at the end, they'll be answering the questions live. And with that, I would like to turn the floor over to our 2 speakers, and I look forward to learning all about MBMA. Marion and Matt, the floor is yours.
Thanks, Stacy. All right, let's kick this off. Hello, everyone, and welcome to the ISoP ASA sponsored webinar on the Introduction to Model-Based Meta-Analysis. My name is Matt Zierhut, and I'm joined by Marion Bouillon-Pichault. We'd like to thank the SxP Special Interest Group for inviting us to speak today, particularly Stacy Tannenbaum, our host. And we'd like to thank all of you, the audience, for joining in what we feel is a very interesting topic.
Hello, my name is Marion Bouillon-Pichault, and it is my great pleasure to tell you about MBMA. I am a pharmacometrician by initial training, and over the last 10 years, I have had several pharmacometrics roles in consulting and pharma companies in Europe and in the US. My passion is to leverage available data through mathematical modeling to address key development questions. I joined Mbmas in 2015, where I am currently leading the effort to implement Mbmas to support drug development on the BMS portfolio.
And again, my name is Matt Zierhut. I have a background in engineering, a PhD in bioengineering, and I recently received an MBA, both from UC Berkeley. I have some brief experience in management consulting, but most of my 12 years work experience has been in the pharmaceutical industry, where I focused on clinical pharmacology, pharmacometrics, and statistics. Now I really focus on utilizing modeling and simulation-based methods to inform drug development decisions, mainly through the application of model-based meta-analysis. I've been at Janssen since 2016, where I'm leading a team to integrate the external aggregate clinical trial data that we use in model-based meta-analysis to improve decision-making across all of the therapeutic areas at Janssen.
Let's start by defining what you can expect from that webinar. We would like to provide you an understanding of what an MBMA is and how it can be performed. To do that, we will spend some time talking about the data. Then, we will switch to the methodology and try to position MBMA versus classical meta-analysis and pharmacometrics. We will move to potential application to support drug development, and we will finish by presenting 3 MBMA examples. Also, I wanted to remind you to send your comments and questions in the Zoom chat box. We will address them at the end of the presentation. I would like to start with an analogy with recycling. A definition of recycle is to process used materials so as to make it suitable for reuse. In that sense, MBMA is a way of recycling as we process, we model the already used data so as to make it suitable for supporting drug development. MBMA can be defined as a tool for integrating prior knowledge and using it to inform development decisions. As I mentioned, MBMA relies on already published data. It is a data-driven approach. We use this data, which is usually aggregated, to develop a mathematical model to describe efficacy, safety, PK, PD, in order to address your question of interest. By integrating the totality of available information, we potentially have access to a wide range of indication, mechanism of action, etc. But since data come from potentially highly heterogeneously designed trials, it is associated with inter-trial variability that we need to quantify.
Thinking a bit higher level now, in any analysis, what we're really trying to do is utilize all the available data to improve our decision making. And the way we can do that is to develop a predictive model based on our data. These predictive models can help with drug development decisions mainly, but they can also help with commercial, marketing, or other critical business decisions. Here I've divided the types of data up into a 2x2 matrix, a very simplified version of the data that are available for predictive modeling. And you can see in the top left, the green quadrant is data coming from clinical trials at the patient level. This is really what pharmaceutical companies generate. You run clinical trials to generate these data and analyze these data. There's also a vast amount of data available from the real world or outside of clinical trials. And this is available through electronic health records or patient level data from insurance claims databases, things like that. And there's a large movement to analyze these types of data and improve decision making, rightly so. But there's another quadrant down here in the lower left, shown in blue. And this is summary level data that's available publicly from published clinical trial results. This is what I'm terming exact data. for external aggregate clinical trial data. And I think this is really where there's an untapped potential. This is where we can apply model-based meta-analysis to really learn more about what's going on in the landscape of various indications that have run clinical trials. So let's discuss more specifics of external aggregate clinical trial or exact data. There is actually a tremendous opportunity to create knowledge through the integration of this publicly available exact data. And the data usually comes from sources like peer-reviewed journal articles, but it could also come from clinicaltrials.gov or other sources that may be published from sponsors' websites. However, there are challenges that exist when using these data. As in any analysis, the quality of the data determines the utility of the analysis. And to avoid potential bias in this approach, you need to put forth a systematic, objective data curation process. And this process is not trivial, as reporting the clinical trial results is not always standardized. You may have different definitions for different variables or endpoints, and you have to be creative in thinking of ways to incorporate all this data into one model. Now, model-based meta-analysis is not the only methodology that exists to analyze these exact data. There's many summary type approaches that have been around for many, many years. Mostly pairwise meta-analysis and network meta-analysis. Model-based meta-analysis is an extension of those other meta-analysis approaches, mainly focused on developing a predictive model. And there's other different types of approaches as well, like the more well-known in the market access field, matching adjusted indirect comparisons, or other types of indirect comparisons or comparisons using the published exact data. Diving a bit deeper into meta-analysis and the concepts involved in meta-analysis or meta-analytic techniques, just wanted to kind of progress through some of the concepts that are typically captured or utilized when performing a model-based meta-analysis. The univariate meta-analysis can involve both fixed and random effects. And the goal there is really to get a weighted average of the effect size, where a random effect can be used to capture between study variability. The next concept would be meta-regression, where you can perform regression analyses on aggregate data to understand how certain characteristics, whether they are population characteristics or trial characteristics, how they may influence between study variability. Then there's also the ability to model multiple endpoints simultaneously, or a multivariate meta-analysis. This is useful when you have endpoints that might be correlated within a study, for example, from a Kaplan-Meier curve. And finally, model-based meta-analysis is a tool that allows you to incorporate all of these concepts into one, well-organized methodology, and it's typically used to capture either longitudinal or multivariate or just landmark meta-regression techniques. And the purpose, again, is to develop a parametric model to capture the influence of many different factors and end up with a predictive model. The Mbma comes from more of a pharmacological approach, which is where it's very related to pharmacometrics. Frequently, you'll find model-based analysis as part of a pharmacometrics organization. But there's also very, very much pharmacostatistical methods at play here, mainly around the correlations and the random effects that need to be taken into account, which are a little bit beyond the typical pharmacometrics approach. So now, how are model-based meta-analyses typically used or integrated into a drug development program? As we said earlier, Mbma is really a tool for integrating this prior knowledge and using it to inform development decisions. Again, through developing a predictive model based on the summary level or aggregate data, we can describe how the various trial endpoints are affected by interventions or treatments, as well as other factors that we would capture as covariates. Now, how we apply this model, there's multiple ways to apply it. I'm only listing a handful of representative applications here, but probably the most common way is to assess the landscape of available treatments and really establish what is the bar necessary. What is the safety and efficacy you would need to see in a new drug to constitute differentiation from what is already out there. Another application here is once you have data from a trial, you can place those results in the proper context of what is already known through this meta-analysis. Both internal and external data that are available can be used for the context of our new results. And then I can simulate head-to-head clinical trials based on the direct as well as indirect evidence that we have in our trial network. Also, we can quantify how influential certain factors are, how certain population or trial characteristics contribute to variability in the outcomes, and we could potentially enrich a future trial with a population or a specific design that optimizes our probability of trial success. We can also use model-based meta-analysis to help optimize dose selection and improve clinical study design through sample size selection, the duration of the study, et cetera. And really, we like to use clinical trial simulation using the model-based meta-analysis to drive that simulation and help us define and evaluate decision criteria and really predict the probability of technical success in an iterative fashion that can be updated as new data become available. And another application is to provide evidence for potential surrogate endpoints, whether it's for internal decisions or potentially regulatory interactions, but to show that certain endpoints, early endpoints, can be predictive of a later, more clinically relevant endpoint.
Now, I would like to focus on the main differences between model-based meta-analysis and classical pairwise meta-analysis, as Matt has just mentioned, and between model-based meta-analysis and pharmacometrics analysis. To assess the profile of each compound, classical meta-analysis would focus on combining and summarizing the results of several RCTs. On the other hand, Mbma could quantify the efficacy or safety profile for each compound, not focusing on comparison of two compounds. Within a given trial, a classical meta-analysis wouldn't usually use the totality of the information. For example, for survival endpoints, meta-analysis would focus on hazard ratio, or OR, which is a single metric to summarize the survival curve. On the other hand, Mbma has the ability to use the totality of the survival curve by, for example, using fully parametric model. Finally, Mbma can account for the heterogeneity of the included trials. In a classical meta-analysis, you can usually only compare trials that are similar in terms of design, population, etc. An Mbma would quantify and account for these differences, making it a very powerful tool. On the other side, we have pharmacometrics analysis that can be defined as the development of mathematical model to describe the PK, the PD, efficacy, safety. Pharmacometrics is based on individual patient data level, which provide a wealth of information with a low granularity and can lead to conclusion on the individual patient level. However, these conclusions are usually not applicable to non-internal assets because of the lack of access of individual patient data level. The inclusion of a large number of drugs across several different mechanisms of action can help differentiate the drug class from the drug-specific effects. Also, Mbma can help better characterize some characteristics that are likely to be similar with a given mechanism of action. For example, the shape of the dose-response relationship, or the impact of some characteristics. Now that we have defined what MBMA is, let's try and outline what it can be used for. We all agree on the fact that drug development is getting more and more competitive. It is fast path. So how can MBMA help? In the following slides, I have gathered a few examples of application of MBMAs and added a reference that illustrates this application. First, it can contextualize its study results within the current therapeutic landscape, taking into account the specific characteristic on the trial. By quantifying the impact of these characteristics, such as population, trial design, biomarker, one can quantify the clinical target opportunity profile. Checchio et al. Provided a nice illustration of it in 2017. Second, even though new compounds need to differentiate from standard of care and from competitors, trials comparing an asset to the competitors are rarely run. MBMA can help by enabling the simulation of head-to-head trials in that setting, where there is no direct comparison of the asset under development and a comparator. Demin et al. Published an example of this differentiation in rheumatoid arthritis in 2012. Drug development requires a good understanding of the disease. For example, assessing the onset of action or the maintenance effect of an asset can be supported by understanding the time course of the placebo response. MBMA can thus generate hypotheses and propose alternative design for future trials with different timing of interim analysis, alternative endpoint, etc. I will provide some details on the publication by Leil et al. In the following slides. Finally, a strong understanding of the mechanism of action of an asset is needed. It can be challenged by the limitation of the available data for that specific asset. For example, the quantification of a dose-response relationship is limited by the range of investigated dose level of a given asset. But by leveraging the information available for other compounds with a shared mechanism of action, MBMA can enable a robust quantification of a dose-response relationship. This is what was achieved by Boyd et al. In 2017 for oral anticoagulants.
Before moving to examples of applications of MBMA, I just wanted to highlight a few aspects of how MBMA can improve drug development. So as we said earlier, we can use MBMA to rigorously establish safety and efficacy targets that are needed for differentiation. And this really helps you understand what is truly needed to compete in a market when developing a new compound. We can also use MBMA to use simulation-based methods to design cost-effective trials that improve probability of early correct kiss or kill decisions or go or no-go decisions. And this helps to maximize the return on investment on either a trial by trial or a program by program basis if you have a larger portfolio. We can then iteratively quantify the probability of technical success as new data become available and improve the model-based meta-analysis at each step, at each stage that new data are available. And this really helps get a database estimate of the probability of technical and regulatory success, as well as the expected net present value of a compound, a program, a portfolio, whatever level you want to look at. And there's additional benefits across the organization, beyond clinical development or drug development, market access, commercial analytics, licensing and acquisitions. All these areas can really benefit from methodologies like MBMA, definitely from the external aggregate clinical trial data. And I just want to remind everybody, if you have any comments or questions about any of these concepts or topics, please feel free to use the Zoom chat box functionality, and we'll address those after the presentation. Thanks.
Let's move to examples of MBMA and their impact in drug development. The first example is in rheumatoid arthritis, or RA. It is an autoimmune inflammation of synovial joints characterized by immune cell infiltration, cytokine production, and loss of cartilage and bone. Measuring the efficacy of treatments in RA relies on different composite endpoints. ACR 20, 50, 70 measures the reduction in swollen tender joint count and reported outcome. It is dichotomous on individual level, meaning that a patient either reaches or does not reach the given ACR. On the contrary, on the aggregate level, you consider the percentage of patients that reaches a given ACR. The time course of the aggregate level ACR is known to change between drugs between week 12 and week 52, which is the reason why modeling the full time course and not considering a specific time point is of tremendous importance. On top of that, ACR 20 is required by the FDA. On the other hand, DAS28 is an absolute measurement of RA disease activity. It is a continuous score, and it is widely used in clinical trial, especially earlier in development, although it is not required by the FDA. As for ACR, DAS28 time course is specific to each drug, and looking at one single time point might lead to partial information. The characterization of the full-time course of DAS28 could bring valuable information for clinical trial designs, as I will show in the following slides. An Mbma was developed to describe the time course of DAS28 for the RA therapeutic landscape. Its aim was to inform the design of internal phase 2 trials in RA. We were particularly interested in addressing questions on the duration of the trials and the timing of the interim analysis. Thus, quantifying the longitudinal behavior of DAS28 in clinical trials was needed. Also, we wanted to determine the potential competitiveness of our internal assets versus the already developed competitors over time. The data used for this analysis comprised more than 300 published references describing 130 trials for a total of more than 27,000 patients. They covered 7 approved drugs in 5 distinct mechanisms of action. Several structural models were tested to describe the DAS28 time course. Among the investigated structural models, the one that best fitted the data was an Emax model with a yield function. In this model, the drug effect is additive to placebo effect, and Emax and ET50 are estimated for each drug. A progression term, prog, is added to describe the worsening of the disease over time, meaning that DAS28 tends to increase with time. Mbma usually requires a complex set of variability models. In that example, the trial was identified as the ID, enabling the quantification of an inter-trial variability. An additional level of variability was quantified on the treatment arm level, the inter-arm variability. And last, the residual variability was applied to the observation level. Because we are considering aggregate data, the endpoint is the mean DAS28. Some mean DAS28 can come from trials arms, including a larger number of patients, when other mean DAS28 come from a smaller group of patients. You want to give more weight to the information coming from more patients. To do so, the inter-arms and the residual variability are inversely weighted by the size of the given arm. Several covariates were identified on the trial level. Baseline DAS28 was a significant covariate on both placebo Emax and placebo ET50. Higher baseline DAS28 is associated with a slightly greater maximum placebo response, roughly 0.7% per DAS28 unit, and a longer time to maximum placebo response, around 24% per DAS28 unit. Both of these effects are likely due to an intrinsic relationship between baseline DAS28 and the DAS28 change over time. Disease duration was a significant covariate on placebo Emax. Longer disease duration was associated with a reduced placebo effect, roughly 0.8% per 5 years, which is consistent with the known effect of disease duration on clinical response to RA. Trial year was a significant covariate on the progression term, prog. Earlier trials tended to have a greater background DAS28 progression compared with more recent one, around 0.31 DAS28 units per year in 2000 versus 0.025 DAS28 units per year in 2016. This is likely associated with an improvement in the background DMARD therapies and their administration or compliance over the years. A reduction in baseline disease activity, as measured by DAS28, has been observed in clinical trials conducted from 2000 to 2010. On the right-hand side are plotted VPC broken down per drug. The circles represent the observed mean DAS28, and their size are proportional to the number of patients included in the treatment arm. You can see that the model correctly quantifies the time course of DAS28 for all drugs included in the Mbma, as well as their variability. The final model was used to run extensive simulations of DAS28 change from baseline on the left-hand side and placebo-corrected DAS28 change from baseline on the right-hand side. It enables to quantify and rank the efficacy over time of the different drugs included in the Mbma. You can see that most drugs have achieved their maximum treatment effect by week 12. Onset of action for Ritaximab, Certolizumab, and Tocilizumab appears longer. This is already an interesting piece of information. Additionally, the development team was interested in evaluating the interim analysis timing, that is to say, to determine when does the treatment effect differ significantly from placebo for drugs that have proven to be efficacious. Another interesting question is to quantify what would be an appropriate sample size and probability of success on prior approved therapy. To address these two questions, extensive clinical trial simulations were run. On the left-hand side, you can see the probability to detect the difference from placebo with 75 patients per arm at different time points. You can see that at week 4, all approved therapies, except from Ritaximab, show a higher than 75% probability to detect treatment effect, meaning that week 4 seems a reasonable timeline to conduct an interim analysis. This conclusion led to having interim analysis at week 4 for some internal BMS trial. On the right-hand side, you can see the probability to detect a difference from placebo at week 4 with increasing number of patients per arm. You can see that with 75 patients per arms, all drugs but Ritaximab have more than 75% chances to detect difference from placebo, meaning that 75 patients per arm are required. This is an example where Mbma has had a significant impact on design of further internal trials in RA. I will hand it over to Matt now to move to the second example.
For the second example, I'd like to talk about how we use Mbma to improve the development of a new multiple sclerosis compound. If you're not familiar, multiple sclerosis, or MS, is an inflammatory autoimmune disorder of the central nervous system, and it's the most common cause of progressive neurological disability in young adults. So at Janssen, we are currently developing ponesimod, which is an oral treatment option for patients with relapsing forms of multiple sclerosis. Recently, the phase 3 trial, the Optimum study, read out that evaluated the safety and efficacy of ponesimod versus an active comparator, teriflunomide. However, comparison versus placebo was also considered critical to fully characterize its efficacy profile. Now, again, model-based meta-analysis is a tool that can assimilate publicly available external clinical trial results into a predictive model. And in this case, allows us to compare compounds in the trial network as if they were all tested in the same trial, the indirect treatment comparison. And the MBMA also places our new trial results from this phase 3 optimum study in the proper context of what is already known, both available, internal and external data. The specific objectives of model-based meta-analysis in multiple sclerosis here was primarily to develop a predictive model to quantify the competitive landscape for treatments of relapsing MS measured by 2 endpoints. The first endpoint is involves serial assessments of the proportion of patients that meet a threshold for confirmed disability. And that is a confirmed disability accumulation that's been sustained for 12 weeks. We'll call that the 12-week CDA endpoint. The other endpoint of interest is mean annualized relapse rate, or ARR, and that is the mean number of events per patient year. The second objective is to incorporate the phase 3 optimum study results into this predictive model, and then use that to predict the relative treatment effects for the ponesimod 20 milligram dose of ponesimod versus placebo, as well as other treatments using these 2 endpoints, 12-week CDA and mean ARR. But the relative treatment effect of these endpoints will be measured as hazard ratio for 12-week CDA and the rate ratio for the mean ARR. So only trials with that met certain criteria were included in this analysis. Specifically, the trials had to have they had to be randomized controlled trials, and they had to have at least 25 patients in each treatment arm. They had to have patients with relapsing forms of MS. That was a mandatory inclusion criteria, and we only looked at trials studying monotherapy. There was no add-on or combo therapy arms included. And then finally, all trials had to be at least 48 weeks in duration. And what you see on the right of this slide is the trial network of the drugs that were included in our analysis database. The table on the bottom shows the breakdown of each endpoint, the 12-week CDA and the mean ARR. You'll see that there were 26 trials with CDA data and 41 trials with ARR data, and more arms, because these are all randomized controlled trials. So there were 69 CDA trials and or 69 arms within the CDA trials and 106 arms within the ARR trials. Finally, the CDA endpoint was a longitudinal endpoint, so we had more data points than we did arms, but the mean ARR was a landmark analysis, so we had the same number of data points as we did arms. And overall, the data here represented just shy of 34,000 patients. Now, these 2 figures are meant to be illustrative summaries of the data for each endpoint. The longitudinal 12-week CDA data are shown on the left. This is longitudinal data that has been digitized from Kaplan-Meier-like curves of the cumulative proportion of patients that have had this 12-week CDA event, color-coded by the different treatments in each trial. The size of the symbols represent the number of patients in each of those trials, or each of those measured data points. Now, the figure on the right represents the landmark mean ARR data, again, color-coded by treatment, where symbol size represents number of patients. But the lines connecting the symbols represent treatments that were compared in a head-to-head trial. So this is intended just to get a glimpse of what the raw data look like in this analysis data set. Now, focusing a bit on the methods of the modeling portion of the analysis, for the 12-week CDA endpoint, again, we have longitudinal data, and we apply a non-parametric placebo estimation to develop this predictive model to predict the probability of a 12-week CDA event. We assumed the data followed a Weibull distribution So we used a complementary log-log transformation, and that essentially allows us to capture the relationship of CDA probability over time and assuming proportional hazards between all the treatments, and the hazard ratios remain constant over time. The equation shown here again shows what I just stated. It's the dependent variable is the probability of a CDA event, and it's modeled using a complementary log-log transformation with a non-parametric placebo approach. And in this case, the drug effect can be interpreted as a log hazard ratio. And finally, the weighting of the data here is assumed to follow kind of a deterministic standard error, or based on a proportion. So the standard error of a proportion is shown there as square root of p times 1 minus p over n, where p is the probability of an event and n is the number of patients. And finally, actually, we have a correlation as well. Serial correlation is captured to ensure that the data are not overweighted. Longitudinal data in this case are definitely correlated, and as was the case in this example. A very similar approach was taken for the mean ARR model. Again, we used a non-parametric placebo approach, but in this case, we did not have longitudinal data. We had landmark data of the number of and the annualized relapse rate is the number of relapses per patient year. So we assumed a Poisson weighting, and we log transformed the data. Very similar non-parametric placebo parameterization with a drug effect, in this case representing the log rate ratio for the treatment effect. And then the data were weighted based on our Poisson assumption, based on the predicted mean ARR divided by the number of patients times the duration of the trial at the time of measurement. We also explored multiple effect modifiers, or variables that could be included as covariates or effect modifiers in the model. Those are listed here, with the only one being included that was found to be meaningful or significant being the proportion of patients that received disease-modifying treatment within the past 2 years. We also looked at other potential effect modifiers that were not deemed relevant or meaningful. Now, once we incorporated the dose response, as well as the covariate just mentioned, the proportion of patients receiving DMT in the past 2 years, we had model estimates, parameter estimates, and then those parameter estimates we could essentially draw from the expected distribution based on the estimated uncertainty, and then use that to estimate confidence intervals of the treatment effect. In this case, everything was parameterized to be relative to placebo, but we could also calculate them to be relative to any other drug in the trial network. And again, for the CDA endpoint, we were interested in the hazard ratio, and for the ARR endpoint, we were interested in the rate ratio. Here we see the results for the 12-week CDA longitudinal model. What you see is a forest plot of the hazard ratio of each of the comparator drugs shown in the column on the left relative to placebo. So a hazard ratio greater than 1 suggests that the comparator drug is more likely to result in more 12-week CDA or disability events. And a hazard ratio less than 1 would suggest that the comparator is less likely to result in those disability events. You'll notice that above the dotted line on this figure are the monoclonal antibodies that are available in this network of trials. And below the dotted line are the either drugs that are in a similar class to ponesimod, or drugs that have been available for a longer time than obviously some of the newer drugs. What is interesting to see is in the parentheses on the right, just to the right of the prediction and confidence intervals, 95% confidence intervals, you see the probability that ponesimod is more effective than the comparator. And essentially what this is the percentage of the simulated hazard ratio that lies above 1. So for some of these drugs, you can see that the probability is quite high that ponesimod is more effective. And also there is this simulation is, or these results are relative to a reference of no prior disease modifying therapy in the prior 2 years. But that was also incorporated in this, not shown in these results, but that's also another factor that can be incorporated into a forest plot. Here we see similar results, but these are the results for the mean ARR model. And now we're looking at rate ratio instead of hazard ratio. Again, a rate ratio greater than 1 would suggest the comparator is more likely to result in relapse rates, or a higher relapse rate, whereas a rate ratio below 1 would suggest the comparator may be less likely than ponesimod to have would have lower relapse rate. And again, the monoclonal antibodies are shown on the top with some of the older or similar compounds to ponesimod shown below there. And again, the probability that ponesimod is more effective is shown in parentheses to the right of the confidence intervals. And as before, the influence of prior DMT in the prior 2 years is also incorporated, but the difference between prior treatment and not is not shown in these results. So just I want to briefly talk about some of the caveats and assumptions involved with these modeling approaches. First, the constant hazard ratio across time was assumed for the CDA model using a Weibull distribution and the complementary log-log transformation. Also, I didn't go deep into it, but we did have a dose response for those drugs that had a range of doses in these trials. But this was, again, only captured for the drugs that had a range of doses. And of those, there was most of them only had 2 doses, maybe very few had 3, and a linear dose response was used to capture that relationship. This would mean that you need to have caution if you're going to project any doses that weren't tested, because it may not be a perfectly linear relationship. Also, the impact of the prior DMT was on the drug effect was assumed to be consistent across all drugs. There was no drug-specific covariate influence. It was a universal covariate influence across all drug treatment effects. Finally, there's a couple of statements I like to make about model-based meta-analysis in here. That we are doing meta-regression, and there is a bit lower power to detect covariate relationships compared to, say, patient-level data. So there may be important covariate relationships that exist that were not detectable, where potentially we could analyze patient-level data to understand a bit more about what might be driving some of the variability in outcomes. However, the covariate effects that we did estimate here should only be interpreted at the population level, and any effects that might be present at a patient level may not be apparent at a population level like we have here. And that is really just another way of stating the ecological fallacy. We really want to make sure we're making inferences at a population level when we're working with population level data or aggregate data. So in conclusion, we were able to develop 2 separate predictive models for endpoints in relapsing multiple sclerosis based on publicly available external aggregate clinical trial data. And these models enable the quantification of both the proportion of patients achieving a CDA event longitudinally, as well as the annualized relapse rate in a broad pool of multiple sclerosis trials that in the model also accounted for sources of heterogeneity as effect modifiers, mainly the dose and the presence or the percent of patients that had a prior disease modifying treatment. Then after including the phase 3 optimum results, we were able to predict how well oral ponesimod at 20 milligrams compares to some of these drugs. And the results suggest that it is likely to significantly reduce the proportion of patients achieving the 12-week CDA events, as well as reducing the annualized relapse rate. Definitely compared to placebo, as well as compared to multiple other currently available relapsing multiple sclerosis treatments. The results that we've presented here have been incorporated into recent regulatory documents to support the ponesimod submission, to support the claim that is an effective treatment for adults with relapsing forms of multiple sclerosis. And finally, the longitudinal MBMA and landmark MBMA that we used here are easily extended to other compounds and other indications with similar development questions, and as long as there's sufficient exact aggregate data available to perform those analyses.
Let's move to the last example. Adenocarcinoma of the pancreas, or pancreatic cancer, is a leading cause of death as it is ranked third most deadly cancer in the US. The standard of care is based on chemotherapy combination, and currently there are no global evaluation of the treatment landscape available. The aim of this analysis was to develop a modeling framework for chemotherapies to quantify the landscape of available treatment in pancreatic cancer. Some potential application could be to simulate head-to-head comparison and position an asset under development within the therapeutic landscape, but also to quantify the false positive or false negative rate of a trial, or evaluate a clinical trial design by quantifying the probability of clinical success, as I will describe in the following slides. To develop this MBMA, the data came from 97 published randomized and non-randomized clinical trials. They covered 9 treatment groups and comprised almost 2,500 digitized PFS time points, covering more than 13,000 patients. For that analysis, we applied the algorithm published by Zierhut et al. In 2012 to reconstruct IPD. Let's take a step back and talk about individual patient data level MBMA, or IPD MBMA. Modeling of IPD is the gold standard, as it provides highly informative data with a low granularity. Unfortunately, IPD is usually not available for assets outside of the internal ones. Approaches have been described to reconstruct IPD from digitized survival curves. They all rely on the same principle of leveraging the available information in the survival curve and in the number at risk for different time points to generate some time of event or dropout for synthetic patients. There are several interests in doing so. First, the same type of model could be applied to this reconstructed dataset as to regular IPD. For example, fully parametric time to event model could be applied, which usually provide a fit closer to the data. It could also enable a quantification not only of the event, but also of the dropout or censoring. The main interests of fully parametric models are their ability to be used to run simulations, and that provide much more flexibility in the application of such an MBMA. On the other hand, this approach has several limitations. First, it is quite time-consuming because the application of these algorithms are not that straightforward, and because the dataset they generate can get huge and require a significant amount of computing time. More importantly, the information provided in these datasets that are potential covariates or predictors are still on the average on the population, which means that the conclusion and application of such an analysis has to remain on the population level, as for many MBMA. That's what Matt alluded to in the conclusion of the previous example. In that case, it is particularly misleading because the data used is on individual level. In this example, we applied a fully parametric TTE model on reconstructed data using Monolix 2019 to describe both dropout and PFS. Dropout was best described by a Gompert model. It quantified that dropout would happen later in treated arms of older trials and in population with less than 100% of metastatic patients. PFS was best described by a Weibull model. The final model estimated the PFS for each treatment group, with GEM-S1 combination having the highest PFS and placebo having the lowest PFS. It also quantified that PFS was higher in recent trials and in population with first-line patients and a high proportion of non-metastatic patients. On the right-hand side, the graph represents a VPC for 4 treatment groups, namely gemcitabine-based treatment in red, gemcitabine S1 combination in blue, placebo in navy, and other drug class in gray. The dotted line represents the observation, that is to say the Kaplan-Meier curves constructed by pulling together the reconstructed patients from trials investigating the given treatment. The solid lines are the median of the VPC. This graph does not show the variability of the prediction for the sake of clarity, but you can see that the model correctly captures the different survival associated with each treatment group. A straightforward application of MBMA is the quantification of the therapeutic landscape. You can find an example on that slide. The final model was used to run extensive simulations for specific scenarios. On the left-hand side, simulation of the dropout corrected PFS for the 9 treatment groups are plotted for a first-line population in a trial starting in 2015. It helps visualize that GEM-S1 has the best survival in that specific subpopulation and placebo the worst. Simulations can be performed for alternative scenarios. For example, simulated dropout corrected median PFS time for some selected scenarios are gathered in the table on the right-hand side. It illustrates the impact of the different covariates identified in the model, namely the line of therapy, the year at which the trial was initiated, and the percentage of metastatic patients. Clinical trials are extremely costly for patients and for pharma companies. Quantifying upfront the probability of detecting a given criteria with a design or the clinical probability of success can be highly valuable, and proposing alternatives to improve these probabilities could be of tremendous importance. To do that, we have run extensive clinical trial simulations of a 2-arm clinical trial. The control arm includes 20 patients receiving FOLFIRI plus 20 patients receiving gem/nab-paclitaxel. The treated arm includes 40 patients receiving an hypothetical drugs with an increasing simulated efficacy. This CT would include 70% metastatic patients and would have started in 2015. Delta median PFS was computed for each simulated trial. For each value of delta median PFS used for simulation on the x-axis, you can identify the simulated or detected delta median PFS, and you can quantify the probability of this detected delta median PFS to be equal or higher than a given threshold, represented here by the different curves. For example, you have 80% chances to detect respectively a delta median PFS of 8 weeks or 12 weeks if the tested drug has a delta median PFS of 17 or 22 weeks. Oftentimes, go-no-go decisions are based on results of trial with a limited number of patients. Quantifying the risk of the real efficacy to be higher than what is actually detected, false negative rates, or on the contrary, the risk of the real efficacy to be lower than what is actually detected, false positive rates, can be of tremendous importance. To do that, we have run extensive simulation with the same scenarios as previously described. It is a two-arm clinical trials in which the control arm includes 20 patients receiving FOLFIRI plus 20 patients receiving gem/nab-paclitaxel. The treated arm includes 40 patients receiving an hypothetical drug with an increasing simulated efficacy. As previously described, this clinical trial simulation would include 70% of metastatic patients and would have started in 2015, and the delta median PFS was computed for each simulated trial. For each simulated delta median PFS, that is to say for each colored line on the graph, you can track the actual value of delta median PFS that was used to generate this simulation, that is to say the true delta median PFS. And you can quantify the probability of this true delta median PFS to be equal or higher than a given threshold. For example, for an observed delta median PFS of 8 weeks, the black curve on the graph, the probability of the true delta median PFS to be higher or equal to 10 weeks is around 39%. This is an example of an MBMA to inform trial design and to de-risk go-no-go decisions using a highly innovative approach.
So just to wrap things up, and hopefully we can have, or at least there's some time for a bit of discussion, at least through the chat functionality here on Zoom. I just wanted to kind of summarize, some of the basics that we were able to share with you today. MBMA, model-based meta-analysis, is intended to facilitate the synthesis of all available clinical trial data, both internal and external data. It's intended to facilitate the synthesis of those data into a predictive model, which can then be applied at many stages of drug development. MBMA-based clinical trial simulations can also be used to improve trial designs and increase the probability of making correct development decisions at the earliest time point. The applications of model-based meta-analysis extend well beyond clinical development into many different functional areas across drug development companies. And finally, to ensure the efficient development of any new compound, model-based meta-analysis should really be initiated as early as possible in the drug development process. Thanks again.
We hope that you enjoyed our presentation. If you are interested by MBMA, want to learn more, have some follow-up questions, or feel you are anywhere on that slide, join us in the Mbma Sub-SIG. You can visit our dedicated webpage and send us an email. We hope to hear from you soon. Bye.
So thank you so much to our speakers. I'd ask them to both turn their cameras back on. And you may notice that Marion has been very, very busy responding to all of the questions because Matt couldn't respond because he was sharing his screen. So I think what I'll do now, if it's okay with you, I'm going to read off some of the questions that came through. Please feel free to continue putting questions in. As a housekeeping note, we will be ending in about 25 minutes. So if we don't get to your question, or if you have any follow-up, please feel free to still put them into the Q&A box. And what we'll do is we'll respond to these in writing. And when we post the recording of the presentation, we will also post the Q&A and all of the responses to those as well. So I apologize if I don't get to your question, but it will be answered in due course. What I'm going to do is prioritize some of the bigger picture questions rather than ones that are specific to your examples, because I figured you can respond to those in writing. And I'll start with a question from BJ. It's known that population-based modeling poses technical challenges, for example, matrix inversion, et cetera. And he was curious to know what kind of technical challenges are usually experienced with MBMA, presuming there would be more due to the heterogeneity, presumably, of the data.
Yeah. So my take on this question, and Vijay, correct me if I'm wrong, the population approach, applies to a population of individuals. Here in a MBMA, it's still a population approach. It's just a population of trials. So really the only difference in my mind is that we add this additional weighting factor on each data point. And then other than that, all the different random effects that are applied where the population is considered a population of trials. So in terms of complications that we have in terms of model optimization, I think it's very similar to what you might see in other individual patient data pharmacometric models, except we tend not to do as complicated of models with the data that we have, the aggregate data. So.
Yeah, if I can add something, I definitely, I'm totally in line with what Matt was saying, sorry. I think to add on that, we tend to try and have a little bit more complex variability model, because we can have some variability on the trial level, on the treatment arm level, and on the residual level, obviously. So that adds some complexity, especially when you have to take into account the number of patients, or you have to weight this type of variability.
Okay, great, thank you. The next question is from Amit. How can MBMA be useful in establishing the value of a surrogate endpoint or biomarker unless the same has been applied also for the competitors for which clinical efficacy data is additionally available?
Yeah, so just my thought on that is you don't necessarily have to have an analysis on the correlation between two endpoints available to you, but you do have to have data from both endpoints available in a clinical trial. So you have to have some kind of data available to allow you to understand how they're related. If you have all trials with one endpoint and totally separate trials with another, I'm not really familiar with any ways to understand how they're going to relate to each other. They need to be coming from the same trial. I hope that answers the question.
If not, please follow up in the Q&A. Marion, did you want to add anything to that?
No, I think Matt did
okay.
correctly address the question.
Great. There was another question from Kevin, whether you have any experience in mixing patient level with study or arm level data.
Yeah, and I think there was a few questions on the same point. So there's a lot of research and publication on how to combine individual patient data level and aggregate data level. I would say that there's no clear consensus right now, and the methodology are not that straightforward, but it's a way to go. On a personal level, I don't have the experience of doing that, but I would be very happy to learn more about it.
Yeah, similarly, I don't have the experience, mainly because for simplicity's sake, I tend to turn the individual patient data we might have into aggregate data and then just do a more simple approach. I think one reason that I've done that is because there's another question about this ecological fallacy, is because when you look at relationships on the individual level, they may not be the same as relationships on the population level. So the ecological fallacy is, making inferences on a population or from individual data, or making inferences on individuals based on population data, and they may not be the same. So I always worry about that when I'm thinking about combining the two sources, aggregate and individual data. But there's been a couple papers, really nice papers that talk about techniques to do that, to combine them. Some of them are, well, I gotta spend some more time really understanding how they're doing it. But I should say it seems like it's possible, but it's not something I have experience with.
All right, so you actually answered the next question I was going to send you from Jeff, which was, what is the ecological fallacy? So thank you for getting ahead of things. Yep. There was a question from Craig about how you include RWE data sets alongside your clinical trial data.
Yeah, that's a good one. Marion, you sound like you had something to say.
Yeah, so once again, there's more and more publication and attempt to do that. I think our real-world data is a potential source of very wealthy data. Once again, there's some publication coming up. We have started to develop a project where we have developed an MBMA on aggregate level data, and we are trying to include some real-world data in it to see and to quantify
first of all, the difference in terms of variability, and if is there any difference, can we quantify that difference? The interest in doing that is that obviously, as you probably have understood, the data to develop an MBMA is limited to what's published. In terms of covariate distribution, for example, we're limited to what's reported in the publication. Well-world data would allow us to have a wider range of covariate, a wider range of data. So that is the interest in trying to implement and to include well-world data within an MBMA framework.
Yeah, and there's also, just inherent differences between the types of data, between the aggregate, what we call exact data, and the real world data. Mainly, one's from clinical trials, one's not. So you have this benefit of the randomization and the control in the clinical trial data that you don't have in the real world data. So there's, you have to make certain assumptions if you do want to combine them. But some things that we've explored doing is essentially generating another clinical trial from the real world data, and then treating that as another trial that we can include in a model-based meta-analysis to see if it kind of improves precision in some estimates. But it's an interesting question that I think we'll be exploring a lot in the future, in the near future. But right now it's still kind of a nascent field or a nascent idea.
Great questions, guys. So thank you so much for being engaged and asking these questions. I have one from Brian asking, when reconstituting individual subjects, is there a preferred way to handle correlated covariates?
Yeah, so that's a good question. So when we reconstruct individual patient data, you have to remember that the covariates are not reconstructed, if I can say. The value of the covariate remain at the aggregate level, that is to say, at the median in the population. So there's no real need to look at the correlation of the covariates in that sense. But that poses a challenge when you develop the model, or more when you want to make conclusion on the model, because, and that's something that I've tried to highlight in the presentation, even though you're dealing with individual patient data level, even if it's reconstructed, all the conclusions have to remain on the population level because of these values of the covariates that remain on the aggregate level.
Matt, you want to add anything?
Well, just in terms of like correlation, if there's related covariates, I mean, really, like in any other pharmacometric model, you have the same situation. If aggregate covariates are correlated with each other, it's the same way to handle it that you would if individual patient level data covariates were correlated with each other. So you can either pick one or the other, or include them both with interaction, or I don't know, same kind of methods apply to deal with that.
All right, great. Lena has a question, how one could account for different inclusion or exclusion criteria, for example, severity of disease, I'm assuming amongst different trials.
Yeah, I think that's probably related to the covariate question. That's how I would approach that. It gets to a point where I personally like to include all data that's possible, and then adjust for their differences with covariates, like differences of inclusion exclusion criteria. But if you have one or two trials that are just so different than all the other trials, it's going to be very difficult to capture that difference with covariates, and you may have to just filter out those trials. So there's a balancing act. You want to have relevant trials, but you can expand a little bit by accounting for differences with covariates, but not too much.
All right, Marion, do you want to add anything?
No, I was about to say through covariates, so it's exactly that.
Okay, great. This one's interesting. From Anders, wondering if there are MBMA examples which incorporate both effect and adverse event outcomes. So he was saying, if he understood correctly, all three examples focus specifically on the beneficial outcomes.
Yep. Yeah, there's a lot of example of MBMA, either only focusing on adverse event, or some MBMA framework, if I can say, that actually develop model to describe efficacy and safety, and that's very useful, because then you can imagine quantifying a balance, benefit risk balance, and you can quantify that, and you can give some recommendations. So yes, indeed, there's a lot of MBMA addressing safety questions.
One recent example of a combined analysis, looking at the anticoagulant landscape. You have kind of a tight therapeutic window there, and you want to understand the dose that leads to a good efficacy, but also not so much bleeding. So we've developed a joint model on both efficacy and bleeding to understand kind of what that window might look like across different treatments.
Great. I'm skipping around in the questions, and indulge me, everyone. I'm sorry if I don't get to your question. I'm kind of looking for ones that are a bigger picture. There was an interesting one from Carolina or Carolina, hopefully one of those is correct, on how you deal with the different imputation methods used across studies. So this could be more of a problem when the length of the study increases.
You want to start, Matt?
Sure. I mean, not every trial is designed the exact same way. So I'm guessing that this is about imputation in, well, maybe I'll read this as imputation of maybe covariates that aren't reported, or is it imputation of how to adjust for a different trial? I mean, if it's a different trial, we would adjust for it with covariates if it's a different design. But if maybe they don't report an important covariate that we want to include, maybe that's what the imputation is getting at. And that's actually a very important part of the, the prep or the pre-analysis or exploratory analysis, especially if you want to include multiple trials and maybe they have information that's related to that endpoint or the covariate they're not reporting. You can kind of develop a pre-model or a model within a model to impute what that covariate might be, even though it's not reported. I don't know, is that your take, Marion?
Yeah, I understood the question as imputing missing covariates, and that's actually indeed, and that's a big, potentially a big issue in Mbma, because as I mentioned, you're limited to the data that is published. And not only sometimes you don't have the covariate that is reported, but sometimes you have the covariate or the biomarker or whatever, which is reported with another unit or another threshold. And there you get into a lot of complication. Sometimes if you have enough information on the individual patient data level for the distribution of a biomarker, for example, if you provided the biomarker to a certain threshold and you're interested in another threshold, you can assume a distribution of that biomarker and then impute the different threshold of the biomarker based on that distribution.
Great. And Caroline, if that did not answer your question, feel free to follow up in the Q&A to specify more specifically what you meant. I'm combining two questions, and I think you've covered some of this already, but oops, I just lost it. If there's individual data available for some trials, is there a benefit to conduct MBMA with the summary level data for trials with no individual data, and the individual data were available? And that's combined with, that's from Shu Ying, and that's combined with a question from Jeff, and he was asking your thoughts about the method published a few years ago by the folks at Metrum for integrating subject level data with summary level data. So I think those are related. Correct me if I'm wrong.
Yeah, and I think that speaks to one question that we already kind of addressed, is modeling of joint model of individual patient data and aggregate level data. Once again, obviously, individual patient data level has a wealth of knowledge, and ideally, you do not want to have to combine them to integrate them in a model. But sometimes the complexity of modeling together individual patient data level and aggregate data level is so important that you have to do that. Once again, I don't have personally the expertise in doing that. It just never happened to me that I had to do that. But once again, there's some publication, one of them by Metrum, about methodology to model jointly individual patient data level and aggregate data level.
Yeah. I mean, just to reiterate, there's even more recent publications, I think, than the Metrum one. But I think to do it the way that the Metrum one was describing, if I'm not mistaken, I think you do have to make the assumption that the covariate relationships at the individual level would be similar to the population level. And it's probably not that crazy of an assumption, but it is something to worry about, this ecological fallacy that we were talking about before.
Great. Getting into a couple of technical questions. Did you try multi-level Bayesian computations that handle various weights and random levels more naturally?
No.
Let me try to simplify that question in my head. I mean, if we're just talking about using Bayesian approaches to the model, where you specify what the uncertainty distribution might look like, prior distribution. I haven't personally done that, but I know people even at Janssen are looking into that. So we typically, another question I think was, what software do we use? I typically use R and then the NLME package, but I know people are looking at using JAGs or Bugs tools to really do the same exact type of modeling, but in a Bayesian framework. So maybe that answers. Great.
And to the person who asked, the webinar is being recorded. It will be posted on our SxP website, probably on both the ASA and the ISoP ones, along with the Q&A. So we'll send out an announcement when all of this is being posted. I'm going to indulge my interest in being the chair of the SxP and also being someone who's very interested in communication to really have the last two questions be about those things. So one from Elodie is publishing these interesting Mbma analyses contributes to the acceptance of the approach and eases its communication to decision makers and helps others build on legacy models. And what's your feeling on only a fraction of these analyses being made within pharma companies and published? Well, the fraction being published that are made within pharma companies.
Yeah, I mean, I'm very guilty of that. I've performed a lot of these analyses and have not been publishing much at all lately. I think I'll try to make an excuse, but it's really not a valid excuse, that a lot of these analyses are used for internal decision making, and maybe people aren't excited to share with the rest of the world what the basis of these decisions are. But I think there's ways to publish it to get around that, and I don't think my excuse is valid. I think it's a great point. There should be more publishing, and I can only say I'll try to do more.
Yeah, I totally agree with what Matt was saying. It's true that in pharma company, we tend to develop Mbma to support a program, and sometimes there's, I would say, decisions that are taken, and the communication, like the publication, can be a little bit difficult for confidentiality reasons. But it's true that Mbma should be publishable even without the internal assets data in it. I think that, as Matt was saying, we're responsible for not putting the last effort to publish it a little bit more.
I think this was you already gave some great examples here and made them public. I know people are asking, if you can provide sample code. I'll let you guys decide whether or not that's possible. But if that is possible, we will also post that along with the supplementary materials. And so now I'll bring up what I think is very relevant to this special interest group from Alex, which is, can you comment on the collaborative work between the statistician and the pharmacometric scientists in Mbma? Who owns which tasks, and how is synergy achieved?
Matt, do you want to start, or should I start?
Sure. I can start. So my background, at Janssen, I started in clinical pharmacology, pharmacometrics related. That's really where my initiation was to the pharmaceutical industry. But for the past 3 years now, I've been in the statistics department. So where I see Mbma sitting is in neither group. It's really kind of in a broader, more of an umbrella, beyond ClinPharm, pharmacometrics, and stats, because it can be applied in so many different departments across the company. It's hard to put it in any, particular bucket. I think it's a bit bigger than both of them, but it definitely should encourage collaboration between the two of them, because it's not statistical modeling, it's not pharmacometric modeling, it's really both.
Yeah, I think from a personal experience, I've been back and forth between. So I'm a pharmacometrician by initial background, and I've been interacting, and I've been part of some statistics and biostats group and teams, back and forth. I think, as Matt rightly said, Mbma is kind of in the cornerstone of pharmacometrics and statistics. That's why we're so happy to be hosted, that the Sub-SIG is hosted in the SxP SIG. And from my personal experience, I think when you start developing an Mbma, you need to engage a lot of people, but you need to engage statisticians. First of all, because they usually have a lot of ideas, good ideas for MBMA, and also because they're part of the project team. So, and I think that requires a lot of diversity and inclusion, because we sometimes do not speak the same vocabulary, for example. But I think MBMA is one of the perfect example to develop this inclusion, diversity, and interaction, collaboration through teams.
Well, that's wonderful. You belong very properly in the SxP. It is about the collaboration between statistics and pharmacometrics and finding out where we can work together. So we're very happy to have you as a subgroup. I'm cognizant of the time. We're reaching the end of our time, but I just want to thank our two speakers so much. I think you recording the presentation, with the exception of the chat. Sorry guys, it didn't work in the beginning, but I think this went really seamlessly, and I like that you were able to answer questions in real time. I hope that was useful for the participants. Please, if you think of additional questions, feel free to reach out to us. If you want to join the SxP, or if you want to join the MBMA SIG subgroup, or both, please reach out to us. You can find us. I did not think to actually find the website for SxP, but please look us up. We're on the Go ISoP website and on the ASA website, and we can put that into the chat if anyone has that readily available. Otherwise, just look us up or contact any of us. If you have any ideas for further SxP webinars, please contact me or Mike Smith or anyone on our steering committee. We're really, really happy to have you kick off our inaugural webinar. So thank you both to Matt and Marion for all your hard work on this. And I will close the meeting now, but please all keep in touch, and we hope that you will join us on the SxP and join us for further webinars. So take care and have a great rest of your day, everyone. Thank you, Matt and Marion.
Thank you. Bye.
Thank you, everyone. Thanks.